Hello, can you hear us?
Yes, sir.
Okay, so good evening. So we welcome all the participants for this fifth issue of OQ Healthscapes today, 30th April 2021. So this OQ Healthscapes fifth issue. So we are doing this sessions every last Friday of every month, and which contains monthly updates on environment and occupational health issues, local, regional, and global, by our one of the most eminent speakers in the country, Dr. Rajiv Kumar Jain, who is a member, management committee, scientific committee on epidemiology and occupational health at ICOH, International Commission on Occupational Health, and is also the vice president of Association of Environment and Occupational Health, Delhi. Dr. Rajiv Jain is a senior consultant health at Indian Railways, New Delhi. He has got 40 years of experience in health and hospital administration, and he has got numerous awards. Just to say, he has got the Fellow Award of Indian Public Health Association and numerous awards. And he has got more than 145 scientific papers in international, national conferences, journals, and books. And as I said, he is one of the most eminent speakers on occupational health in our country. And is also the role model for all the young occupational physicians out there who are looking for a bright career in the field of occupational health. So with this, we'll hand over the floor to Dr. Rajiv Jain. And I request all the participants, of course, we are starting on time. We didn't wait for 2 minutes. So let us be on time. And just like all the corporates, let us be on time. So before I hand over to Dr. Rajiv Jain, so I request you all to mute your microphones. And at the end of the session, definitely we'll have a question and answer sessions. More than Q&A, we want to be an interactive session. And of course, it's always the mutual learning that we are doing here. So with this, I'll hand over this floor to Dr. Rajiv Jain. Sir, the floor is yours.
Thank you, Dr. Guru Prasad, for the kind words. This OQ Healthscapes episode is sixth in the series. So we've crossed now 6 months of this journey of an update on all matters related to environment and occupational health, whether it is local, whether it is regional, or whether it is global. So we cover a landscape, try to cover a wide landscape, because we believe environment and occupational health cannot be separated in the current context or in any time in future. So with this, I would like to, before starting, I would like to also apprise my attendees and all our colleagues in IOH and ICO and AUHD that our Honorary Secretary of AUHD and National Secretary of IOH unfortunately lost his father the day before yesterday. And these are difficult times. And he is in mourning at the moment. And he is, I always pray for giving him and his family strength to bear this irreparable loss. And father's loss is a loss which can never be fulfilled, which can never be replaced. I pray that his soul rests in peace, and I pray to God provide peace in the family. Om Shanti. With this homage to Dr. Sandeep's father, I start with the program of OcuHealthscapes. Today's session is focused on two of the most important matters, which is drawing attention of all the people at the current juncture. One, of course, is the pandemic. And I would like to again state that COVID-19 pandemic is a pandemic of an occupational disease. And one cannot separate COVID-19 pandemic from occupational health now or forever. Second is on 28th of April every year, one celebrates globally the World Day for Safety and Health. And International Labour Organization has declared 28th April as the World Day for Safety and Health. So on that day, a path-breaking report was released. We shall discuss something about that during today's OcuHealthscapes. But before that, as I told you earlier, we shall discuss about the current situation of the coronavirus disease or COVID-19 pandemic globally, regionally, and locally. And we shall also devote some time to the very crucial issue of vaccination against COVID-19, especially in India. So as traditionally, we begin with the global situation. This is the current situation of the WHO coronavirus disease dashboard. Globally, 149 million cases have been reported, out of which Americas have reported 61 million, Europe has reported 51 million, and Southeast Asia region has reported 21.8 million cases. Eastern Mediterranean and Africa and Western Pacific have reported less than 10 million, 9, 3, and 2 million respectively. So global pandemic of unparalleled dimension has been rolling for the last more than 1 year. If we look at the current situation of the last 24 hours, out of 893,000 cases, 402,000 cases were reported from Southeast Asia region, and 223,000 cases were reported from Americas, which includes South and North America, and 195,000 cases were reported from Europe. Eastern Mediterranean reported 47,000 cases, Western Pacific reported 19,000 cases, and Africa reported 5,619 cases. So we can say Southeast Asia region is the epicenter of the world. Americas has a very mixed picture, where some countries are in the receding phase and some countries are still bearing the major brunt, and Europe is still not out of the woods. It is still in the very diverse phase. East European has a different picture, Western Europe has a different picture. If you look at the country comparisons in the WHO coronavirus disease dashboard, we find in terms of new cases detected in the last 24 hours, out of 894,000 cases, 332,000 cases were reported by India, 79,000 cases were reported by Brazil, 62,000 cases were reported by United States. Turkey, such a small country, reported 54,791 cases. France reported 34,000 cases. Germany, 27,000 cases. Argentina, 25,900 cases. So you can imagine this is spread all across the world today with India as epicenter, and it is in the raging phase. An inferno of COVID-19 is visible in India today. 332,000 versus 79,000. You can imagine 1:4, and almost 40% cases reported in 24 hours are reported by India. If we look at the deaths, this is the comparison of deaths occurring in the last 24 hours. Out of 14,876 deaths reported globally, India is at number 1 position in reporting deaths, 3,498 cases of deaths. Brazil reported 3,163. So now, last 24 hours, India has been reporting consistently more deaths than even Brazil. And United States, which are reporting even 5,000 deaths in 24 hours, is reporting 865 deaths in the last 24 hours. Poland is reporting 540 deaths. Colombia reported 490 deaths. Ukraine reported 387 deaths. And Iran, which is Islamic Republic, is 385 deaths. So you can imagine how the situation is changing and how fast the situation is changing. It is very, very dynamic, and it shall continue to be dynamic. But India shall continue to lead for some time, probably for the next 1 month. Very crucial for India's economy and India's health and the health of Indians together. And health and economy can never be separated. And economy, health, and occupational health will never be separated from now onwards. If we look at COVID-19 snapshot for India, last 24 hours, India reported 386,654 cases, 3,501 deaths, and 19.2 lakh tests yesterday. But we shall discuss whether these tests are sufficient or not. 7-day average test positivity rate has gone up to 21%. 1 in 5 are positive in India. 31.6 lakh are active cases and growing at 3.9%, which is doubling in 18 days. Total, India has 18.75 million cases. 2,08,313 lives have been lost officially. About vaccination, 15.22 crore vaccination doses have been given. Yesterday, 2.2 million vaccinations were given. If we look at the states comparison of India in terms of confirmed cases, deaths, tests per million per day, 7-day average test positivity rate in percentage, 7-day average daily growth in percentage, we shall be able to understand where and how much widespread the infection is growing or is rampaging the population and health of economy. If you look at the left column, confirmed cases, out of 386,000 cases, 66,000 were from Maharashtra, Kerala reported 38,000, Uttar Pradesh reported 35,000, Karnataka reported 35,000, Delhi reported 24,000, Tamil Nadu reported 17,800, West Bengal reported 400, Rajasthan reported 70,200, Chhattisgarh reported 15,800, Andhra Pradesh reported 14,700, Gujarat 14,327, Haryana 13,947, Bihar 13,089, Madhya Pradesh 12,700, Telangana 7,994. So these many states which lie in Western India, Southern India, Northern India, and Eastern India as well. So, and Central India as well. So the confirmed cases are raging all across the length and breadth of the country. And mind you, these are very highly populated states all across. And if you see the way things are worsening, all these states at the top 5 have reported the highest number of cases ever during the last more than 1 year. If you look at deaths, out of 3,500 deaths, 771 deaths were reported by Maharashtra, 395 by Delhi, Uttar Pradesh 295, Karnataka 270, Chhattisgarh 251, Gujarat 180, Rajasthan 158, Jharkhand 145, Punjab 137, Tamil Nadu 107, and onwards. These are top 7 states with reporting more than 100 deaths in last 24 hours. Other states have reported less than 100 deaths, but they are also quite substantive, and they are large and small states also. But most important observation on this column is Uttar Pradesh, Karnataka, Rajasthan, Jharkhand have entered the domain of reporting more than 100 deaths every day. So a large number of states are reporting more than 100 deaths every day. And you do not know how many are not reported. So one needs to take this data with a pinch of salt. Tests per million per day, Indian average is 1,418. But if you look at important states of West Bengal, only 545 tests per million per day. Madhya Pradesh 709, Bihar 801, Uttar Pradesh 967, Rajasthan 1073, Andhra Pradesh 1600. So these states, which are large states and have very high population, are testing extremely low levels of population, especially Uttar Pradesh, Bihar, and West Bengal and Madhya Pradesh. If you look at these states, one needs to understand that this positivity rates are not true positivity rates, because the tests being done are reasonably low. If you look at 7-day average and test positivity rate to India, an average is 21%. Look at Goa, it is 40%. Delhi is 32%. West Bengal is 29%. Chhattisgarh is 28%. Haryana is 25%. Maharashtra is 23%. Kerala is 22.9%. Nagaland is 22.7%. Madhya Pradesh is 22.7%. Rajasthan is 21.5%. So these are the states which have more TPR less than the Indian average. But if you look at West Bengal with 29%, and if you combine this figure of huge under testing, you can understand the real positivity rate. If you look at this column of 7-day average daily growth in percentage, which Indian average is 2.06%, Uttarakhand is reporting 3.44, Uttar Pradesh 3.20, Bihar 3.15, Rajasthan is 3.14, Dadra and Nagar Haveli is 3.14, Jharkhand is 3%, Goa is 2.8, Gujarat is 2.87, Haryana is 2.79, Madhya Pradesh is 2.64, Karnataka is 2.41, Chhattisgarh 2.38, Delhi is 2.31, and Himachal is 2.6, Kerala is 2.15, and West Bengal is 2.11. So all these states are showing daily growth percentage higher than Indian average. And these are very wide geography of the country with huge population concentration. If you look at the last column, which is important, vaccinated persons with at least one dose, the Indian average is 9.14%. If you look at states like Uttar Pradesh and Bihar, they lie at the bottom, 4.76 and 4.34%. Only Tamil Nadu is having 5.95%, Meghalaya 6.52%, Jharkhand 6.91%, Nagaland 7.1%, Madhya Pradesh 8.37%, West Bengal 8.71%, and Andhra Pradesh is 9.34%. So these are the states with huge populations have got very little population vaccinated with at least one dose. This is again an analysis of daily COVID-19 vaccinations in India. Even as India is beginning its third phase of COVID-19 vaccination for the 18 plus from tomorrow, that is the 1st of May, the daily jabs continue to fall and are currently at 2.4 million, a 35% fall from its peak. If you look at this figure, you can understand it is going down. 2.445 crore beneficiaries were registered on the COVID as of yesterday. It will be months before they can get a slot. If the slots are not open as yet. If you look at daily new cases is in blue, second dose in gray, the bottom, 7-day moving average, both doses is in green. This graph, 7-day moving average first dose alone is in the yellow. So you can imagine the gap, how the trends between first and second dose and cases and vaccination. These are vaccination, these are cases. How much gap is still there. So we can say with only 2.7% of adults with 18 plus are fully vaccinated and 12.9 given a single dose. At the current daily rate, it will take another more than 2 years to fully vaccinate all the eligible adults in India. So what you require, 7.5 million doses per day, 75 lakh doses should be given daily to fully cover all the adults this year as against the current 2.4 million. So it has to be tripled, 2.4 million to 7.5 million. If we have to cover everybody of 18 plus during this year, 2021 till 31st December 2021. So that is the biggest challenge that India is facing. And at the same time, India is facing a raging pandemic of COVID-19 all across the population, especially the population which are residing in high density areas. So to reflect deeper, this slide shows you wide variance which is persisting in the vaccine coverage achieved by the states. Dark red are early leaders and maintaining the pace, which is in dark. There are 7 states: Chhattisgarh, Delhi, Gujarat, Jammu Kashmir, Kerala, Rajasthan, and Uttarakhand. They were early leaders and they're maintaining their pace. Pink ones are the previous middlers and are maintaining the pace. They are Andhra Pradesh, Haryana, Karnataka, Maharashtra, Odisha, and West Bengal. But look at this. Though they were previous laggards and now increasing the pace, light gray are Punjab and Telangana. But these are the states which require extremely high focused action on improving vaccination. They were laggards earlier and they are laggards now, dark gray. They are Assam, Bihar, Jharkhand, Madhya Pradesh, Tamil Nadu, and Uttar Pradesh. Highly populated states, very vulnerable, and are currently showing a very high uptick of infections. And if you look at the vaccination pace, you would observe from this graph that even as India's COVID-19 infections and deaths are shot up, the country received global attention and help. The US agreed to lift the export ban on raw materials that will allow Serum Institute of India to ramp up the production. Several countries, including the UK, Denmark, and Saudi Arabia, they've extended support by offering essential medicines and equipment. Russia said it will send its first batch of Sputnik 5 vaccines starting 1st of May. Even as India's COVID-19 vaccine doses per capita increased marginally from 11% to 12% in the past week, the pace of increase was among the slowest across the most populous countries globally. Last week, it was 6th among the 10 most populous countries in ramping up vaccine coverage. This week, it was 8th. This is the figure. India is at position 8. And look at Japan. This is weekly change in COVID-19 vaccine doses per 100 people in percentage. Japan is 37%, Brazil is 19%, China 19%, Philippines 15%, Mexico 15%, Bangladesh 12%, Russia 12%, and India 12%. This week, it is 8th. As I told you, Japan registered the fastest growth, but on a low base. The US continued to lead in cumulative vaccine doses administered, 69.5%, and India maintained its 6th position on that metric, 10.5%. 18.5% in Brazil, 16.4% in China, 12.9% in Mexico, Russia 12.7%, which are ahead. This is cumulative COVID-19 vaccination per 100 people. If you look at the infection, how it is spreading, 113 districts have recorded above 5,000 new cases in the past week. New confirmed cases in each district in the last 7 days are shown in this diagram. As new cases continue to break past records, Bangalore urban leads the case tally. Bangalore urban has got 1,26,672 cases. It is twice that of Pune. Pune is having 64,681 and thrice that of Mumbai. Districts it had surpassed earlier as the country's leading hotspot. The new cases in Bangalore urban were 45,000 more than its tally a week before. Lucknow, the capital of Uttar Pradesh, is now ranked 6th in the new caseload. It is 34,400. There were 18 districts from 9 states that added more than 20,000 cases in the past week. In the previous week, there were 11 such districts spread across 6 states. So from 11 districts in 6 states, it has gone to 18 districts in 9 states. This week, 24 of the 36 states and union territories saw double-digit growth in cases. 11 saw more than 20% week-on-week growth, increasing the strain on the healthcare system and intensifying conflicts around oxygen allocation. Tamil Nadu, for example, has complained about oxygen getting diverted to other states. So there's competition, kind of oxygen nationalism has come, sub-nationalism drive is there, and it is raging all across India. Now look at the deaths. Uttar Pradesh and Karnataka show a steep increase in their death curves. If you look at Uttar Pradesh, this one is Uttar Pradesh, and if you look at Karnataka, which is near Uttar Pradesh, you will understand what I'm trying to say. The slant or the gradient of the curve in the recent past is most acute in cases of Uttar Pradesh and Karnataka. COVID deaths have continued to surge across the country, even as underreporting persists. The past week saw the highest number of deaths since the pandemic started, even as the official COVID tally surpassed the 2 lakh mark. On Wednesday, Maharashtra reported 1,035 deaths in one day, its highest ever. Deaths last week in the state accounted for 26% of total deaths in the country. Jharkhand has replaced Chhattisgarh as the state with the biggest surge in COVID-19 deaths, as a weekly death count climbed 35%. Bihar and Delhi's weekly death tally also saw sharp jumps. As cases and deaths continue to mount, states need to redouble their efforts in testing and isolating patients early on to contain the spread of infection. The center and the states also need to address vaccine shortages and vaccine hesitancy on a war footing till we attain herd immunity. You can understand how big are the challenges. On one hand, the infection, the deaths, and on the other, vaccination. Together, it has to be handled on a scale which is more than a war scale and unparalleled in the history of India. Unparalleled in the history of pandemics, I would say. That is what is happening in India now, and especially during the next 1 month across the length and breadth of this country. Now, going beyond COVID-19 pandemic, the World Day for Safety and Health at Work is celebrated on 28th April of every year. And this year also, International Labour Organization called for resilient occupational safety and health systems for future emergencies. The context of COVID-19 pandemic is visible in this ILO report as well. Better national occupational safety and health policies, institutional and regulatory frameworks that are also integrated into crisis response are needed. That's what ILO said on 28th of this month. The occupational safety and health systems, which should be resilient, that would minimize the risks for everyone in the world of work in the event of future health emergencies. This was the core point highlighted in the report of International Labour Organization released on the World Day for Safety and Health at Work on 28th of April. This will require investment in occupational safety and health infrastructure and integrating it into the overall national crisis emergency preparedness and response plans so that workers' safety and health is protected and the business continuity of enterprises is supported. The report, which is titled Anticipate, Prepare and Respond to Crises, Invest Now in Resilient OSH Systems. In the headline, you would understand anticipate, prepare, and respond to crises. It is the plural, not one crisis, number of crises. Invest now in resilient OSH system. This underscores the urgency of investment in resilient occupational safety and health systems all over the world in all the countries. This report examines risk prevention and management relating to the pandemic and analyzes other health and safety risks associated with the changing work arrangements arising from virus control measures. It outlines the critical role played during the pandemic by occupational safety and health regulatory frameworks and institutions, compliance mechanisms, health and advisory services, data, research, and training. These are the dimensions of the report and how each activity plays a critical role. There could be no clearer demonstration of the importance of a strong, resilient occupational safety and health environment. The recovery and prevention will require better national policies, institutional and regulatory frameworks, properly integrated into crisis response framework. This was said by ILO Director General Guy Ryder on 20th of April. Since the COVID-19 pandemic emerged, workers in specific sectors such as emergency, health and social care have been particularly vulnerable to the risk of infection. According to data report, 7,000 health workers have died since the outbreak of the crisis, while 136 million health and social care workers are at risk of contracting COVID-19 through work. The pressures and risks facing health workers during the pandemic have also taken a toll on their mental health. 1 in 5 healthcare workers globally have reported depression and anxiety symptoms, as well as the health and care sectors. Many other workplaces have been sources of COVID-19 outbreaks. When staff are in closed environments or spend time in close proximity with each other, including in shared accommodation or shared transport. And health concerns arising from the dramatic increase in teleworking during the pandemic, the report says that while teleworking has been essential in limiting the spread of the virus, maintaining jobs and business continuity and giving workers increased flexibility, it has also blurred the lines between work and private life. 65% of enterprises surveyed by the ILO and the G20 OSH network reported that worker morale has been difficult to sustain while teleworking. The report says small and micro-sized enterprises have often found it hard to meet official OSH requirements because many have lacked the resources to adapt to the threats posed by the pandemic. In the informal economy, many of the 1.6 billion workers, especially in developing countries, have continued working despite lockdowns, restrictions on movement and social interaction, and other measures. This has put them at high risk of catching the virus, yet most do not have access to basic social protection such as sick leave or sick pay. International labor standards offer specific guidance on how to respond to these challenges, thereby reducing the risk of virus transmission in the workplace. The report says they provide tools to implement occupational safety and health measures and to ensure that workers, employers, and governments can maintain decent work while adjusting to the socio-economic consequences of the pandemic. International labor standards also encourage social dialogue as the best way to ensure that procedures and protocols are effectively implemented. And this is the cover page of the ILO report on the World Day for Safety and Health at Work 2021. As I said, title is Anticipate, Prepare, and Respond to Crises and Invest Now in Resilient Occupational Safety and Health Systems. So from this presentation, I will now take you to the actual report and show you how this makes a read, which is important for all of us to understand and share. This is the table of contents, which is Chapter 1 is National Occupational Safety, Health Policy and Regulatory Framework. Chapter 2 is National Occupational Safety and Health Institutional Framework. Third chapter is Occupational Health Services. Fourth chapter is information, advisory services and training in occupational safety and health. Fifth chapter is data collection and research in occupational safety and health. Sixth chapter is strengthening occupational safety and health management and systems at the enterprise level. And then it has a very good bibliography and very good annexes. And also it has a chapter on looking forward on resilient occupational safety health systems to face the next crisis. If you look at the first chapter on occupational safety and health policy, we would understand how strengthening effective national oversight policies and regulatory framework, they ultimately result in better response to crisis and emergency. They promote a management system approach to OSH, new legal requirement to prevent the spread of the virus in the workplace, adopting provisions to manage associated OSH risks, and mechanisms for ensuring compliance with the national laws and regulations, including systems of inspection. But the most important chapter is chapter 3, which in today's webinar we shall be discussing. And I would like to apprise how important it is for India to adopt a model which develops a national occupational safety health system, especially focused on development of occupational health services in the 7 dimensions, as I will tell you in the subsequent discussion. If you look at the global challenge for safety and health at work, and as told earlier, the pandemic exposed workers and people in the world of work to the risk of infection with novel coronavirus. In some cases, COVID-19 infection may be attributed to workplace exposure and certain workplace settings, such as healthcare and social care. They have been particularly affected. Workplaces in which workers spend time indoors, as I told you, that has been highlighted in this chapter. Graphic shows you occupational safety and health statistics during COVID-19 pandemic. 65% of enterprises are surveyed, 18.7 greater odds of transmission, closed work environments pose, and compared to open air environments. Globally, there are 136 million workers in health and social work who are at serious risk of acquiring COVID-19 in the workplace. 7,000 health workers have workers' death globally may be attributed to COVID-19. European countries, 25% of cases have occurred among healthcare workers. In African countries, health workers constitute more than 5% of cases, with some countries accounting for more than 10%. In Americas, COVID-19 has infected 570,000 healthcare workers and killed 2,500. 14% of all global infection occurred in healthcare workers. 1 in 5 healthcare workers globally have reported depression and anxiety symptoms during the pandemic. The international labor standards provide a tried and trusted foundation for policy response that focus on a recovery that is sustainable and equitable. This is what ILO DG Guy Ryder said, and the crucial role of international labor standards respond to COVID-19. The core standards are 155, 155, and 161 and 187. These are the 3 standards: the Promotional Framework for Occupational Safety and Health Convention 2006, Occupational Safety and Health Services Convention 1985, Occupational Safety and Health Convention 1981, number 155. These are the 3 standards which are the core standards for the topic that we are discussing. I will straight away take you to chapter 3. On occupational health services. Occupational health services look into the effect of work on people's health and conversely, the effect of their health status on the work performance. The COVID-19 pandemic has brought to light more than ever the need for such services to act as a bridge between public health and workplaces. The scope of services during COVID-19 crisis, the Occupational Health Services Convention 1985, which is number 161, defines occupational health services as services dedicated to essentially preventive functions and responsible for advising employers, workers, and their representatives at the enterprise on 2 aspects. A, the requirements for establishing and maintaining a safe and healthy working environment that will facilitate optimal physical and mental health in relation to work. And B, the adaptation of work to the capabilities of workers taking into consideration their state of physical and mental health. The convention, that is Convention 1985, number 161, that occupational health services should include the following functions as appropriate to the occupational risks at the workplace. These are the functions: identification, assessment of risk from health hazards in the workplace, surveillance of factors in their working environment and working practices which may affect workers' health, including sanitary installations, canteens, and housing where these facilities are provided by the employer. Third, advice on planning and organization of work, including the design of workplaces, on the choice, maintenance, and condition of machinery and other equipment, and on substance used in the work. Fourth, participate in the workplace in the development of programs for the improvement of working practices, as well as testing and evaluation of health aspects of new equipment. Fifth, advise on occupational health, safety and hygiene, and on ergonomics and individual and collective protective equipment. Sixth, surveillance of workers' health in relation to work. Seventh, promotion of the adaptation of work to the worker. Eight, contribution to measures of vocational rehabilitation. Nine, collaboration in providing information, training, and education in the field of occupational health and hygiene and ergonomics. 10th, organization of first aid and emergency treatment. And 11th, participation in analysis of occupational accidents and occupational diseases. So these 11 functions are as old as 1985. This is the Convention of Occupational Health Services, number 161. The changes to occupational health services during the pandemic in UK. During the pandemic, occupational health services in UK's National Health Service found themselves overwhelmed, along with the nearly all other health services throughout the country. In response to the unprecedented effects that the pandemic had on workers, occupational health services made various modifications to their model of work. A recent study of occupational health physicians in the UK found that 51% of occupational services had extended their hours to include weekends or out-of-hours services. In addition, 21% employed additional workers. As COVID-19 was a very common concern of workers, many of these services set up a dedicated telephone line and email for injuries. And references Ranka et al. Of 2020. The availability of occupational services has been a global challenge. Adapting occupational health services in times of crisis in the Bronx, New York, United States, a large acute care hospital in the Bronx, United States, known as NYC Health Hospital, had to rapidly adapt that occupational health services when they found themselves at the epicenter of the COVID-19 pandemic in April 2020. In order to efficiently and effectively meet the new needs brought in by the crisis, the hospital occupational health services modified their location, their staffing, and data tracking. The occupational services unit adapted its space to the new requirements by moving to a location closer to the main hospital to reduce the transport needs of sick or injured staff and to be closer to the hospital's laboratory services. The new space, which was a converted section of the ambulatory clinic area, also allowed occupational health services to increase from 4 to 16 rooms. With an increased demand for clinical workers in occupational health services, interdisciplinary staff from across the hospital were redeployed to fulfill their needs. And an enhanced data tracking system allowed staff to track the symptoms of healthcare workers alongside their date of quarantine and expected date of return to work. These rapid, innovative adjustments led to a successful response early in the pandemic. In Singapore, occupational health services in a tertiary hospital in Singapore, a tertiary care hospital in Singapore, adopted a three-pronged approach in response to the COVID-19 pandemic. In order to ensure business continuity and the health and safety of the staff, the hospital occupational health services focused on three key areas. One, individual staff protection. Two, staff workforce protection. And three, the prevention of nosocomial infection. In order to protect individual staff from infection, the hospital occupational health services screened and new workers for their fitness for work, vaccinated against diseases, and provided appropriate PPE depending on the risk of the area. To protect the staff workforce, there was surveillance of all the staff after travel or COVID-19 exposure, including symptom screening and temperature checks. Finally, in order to prevent nosocomial spread throughout the hospital, a standardized report sick protocol was created and return to work assessment was routinely used. This comprehensive approach allowed the hospital to adapt to new challenges brought about by the pandemic and to keep workers and management safe. So monitoring of the working environment risk assessment forms the second dimension of occupational health services. In Netherlands, enterprises are required to hire occupational physicians or engage an occupational health and safety service to be involved in matters such as clearance to return to work or risk assessment. In France, occupational health services also assume an advisory role during risk assessment and with respect to reopening of businesses within the framework of the national protocol to ensure workers' health and safety in the context of the COVID-19 epidemic. In New Zealand, occupational health professionals, specifically those specializing in ergonomics, have helped workers set up ergonomically sound home office environment with information technology, equipment, and supports health family teleworking. Occupational services in the United Arab Emirates have provided a comprehensive surveillance system during the pandemic, which has included ongoing health monitoring, testing, telehealth consultation, and advice on appropriate quarantine timelines. They have also efficiently monitored the status of the entire workforce to aid the management. In New Zealand, occupational health nurses have led contract tracing efforts within many enterprises, advising workers on how and when to self-isolate in case of COVID-19 transmission or close contact with an infected colleague. In Belgium, the United Kingdom, France, and New Zealand, occupational physicians have worked with employers to assess the susceptibility of workers to COVID-19, either on account of their jobs or pre-existing condition. They have sought to find solutions to mitigate risk when necessary, such as isolated offices, teleworking arrangements, and PPE. In France, as part of the nationwide rollout of COVID-19 vaccines, occupational physicians have worked alongside the public health system to vaccinate eligible workers. Workers have not been obliged to receive the vaccine, but may receive it from their occupational physicians when they are eligible in the context of the national vaccination strategy. In order to ensure worker confidentiality, occupational health services have been encouraged to administer vaccines at occupational health center when possible. In terms of advisory role, in Canada, occupational nurses have played a key role in reopening businesses during the pandemic, informing worker of preventive measures, managing worker stress, overexposure, and giving educational information about the virus. Provision of general preventive and curative health services in Italy, the pandemic highlighted the importance of preventive occupational health services as prevention became key in the face of COVID-19, with enterprises shifting from a model of evaluating workers' fitness for work to one of ensuring the job was equipped for the workers' health and safety. In New Zealand, the occupational therapists and psychologists helped workers manage stress and anxiety arising from their work and the pandemic. They also provided support to the management and leadership on how to lead in the context of uncertainty. Collaboration with external services is also an important dimension. And collaboration of occupational services with having close relations with external services and institutions such as the country's general public health system and institutions and facilities in local communities. These relations should start at the level of primary healthcare units and extend to the level of hospital-based specialized services, some of which may also provide occupational health services. They are especially important when workers have to be referred to specialized health services to be appropriately assessed and treated for occupational injuries and diseases, and also provide an opportunity to mitigate the possible adverse effects of non-occupational health problems on attendance and work performance. Emergency response organizations and first aid providers, such as ambulance services, hospital outpatient and emergency clinics, poison control centers, police and the fire brigade, and civic rescue organizations can ensure that expeditious treatment of acute injuries and illnesses and assist in planning for and responding to major emergencies. Appropriate links with social security and health insurance institutions can facilitate the administration of benefits and functioning of the workers' compensation system. So this is chapter 3, which is occupational health services. Chapter 4 is on information, advisory services, and training on occupational safety and health. Chapter 5 is on data collection and research in occupational safety and health. Chapter 6 is on strengthening occupational safety and health management systems at the entire enterprise level. And chapter 7 is on the important looking forward, resilient OHS system to face the next crisis. The COVID-19 pandemic has had a major impact on the world of work. Workers have not only had to run the risk of contracting the virus at the workplace, but they have also been subjected to mobility restriction. There has been an increase in teleworking arrangements and the closure of many commercial and manufacturing activities. The ripple effects of the crisis have in turn impacted the labor market, working conditions, and wages, and in many cases, access to the to protections such as sick leave and social benefit. The pandemic has clearly shown the importance of strengthening and creating resilient OSH systems, and we must carry this lesson with us in the future. The crisis has exemplified the importance of OSH as a key actor within the broader emergency response and public health system. National emergency preparedness and response should actively integrate OSH preparedness within their national emergency plans. Investing in OSH systems will not only contribute towards responding to the current pandemic and recovering faster by avoiding further contagion, but will create resilience to face any future crises that might lie ahead. And in this one, if one looks at the bibliography, is very well organized, and the references and the links provided and the annexes are wonderful. For each chapter, there is specific reference to the source or document of ILO, as well as country documents from different countries that is available. Even Government of India has been quoted in this references. So annexes are also very useful in this report. This is 124 pages report, which is worth a read. For next 1 month, I would say if you read just 10 pages every month, you will finish in 10 days. But it is definitely worth a read. I would say one should read this, because this will give you not only an oversight, this will give you an overview of what need to be done in the years to come. And this is not going to end with the COVID-19 pandemic. The entire healthcare system will also evolve in that process. And it has to evolve with the occupational safety and health system, and especially occupational health system in the country. Thank you so much for giving me an opportunity to share with you local, regional, and global developments in the field of environmental and occupational health today.
Thank you, Dr. Rajiv Jain, for this wonderful insight into the pandemic. We are going through both the local and also the global data. And also, apart from that, you mentioned very well, saying that the pandemic, of course, it's occupational disease. So really, I want to know more about that, and I just want to summarize before that. And also, you took us along. You also mentioned about the vaccination target the Indian should have. Of course, whatever the numbers we are having, the vaccination is very low. We need to have minimum 75 lakhs vaccinations per day to complete all the eligible people vaccinated in this year. And also, it was a very well articulated, the summary of the report of ILO during this World Day for Safety and Health. And the catchy thing was the countries need to put resilient occupational and safety health systems that minimize the risk for everyone in the world of work, in the event of future health emergencies. So the world emergencies need to be highlighted, because we need to be prepared for more emergencies in future. Thanks very much, Dr. Rajiv Jain. And we have a few questions here. I'll be taking the one question. Can you elaborate the difficulty in implementing the vaccination for 18 to 45 years age group by the state government and central government? This is what they have asked.
Well, definitely there are huge challenges, especially 18 to 44. This is the most productive part of the society. And in India, as you know, this forms a major part of our population, whether they are household work people or people who work outside the home. One has to also understand the context in which this is happening. This is happening during the most acute phase of the spread of infection. But if the journey is traveled in a systematic manner, this shall be the most successful vaccination in the history of India. Because this is the real beginning of adult vaccination for this country. We always heard of vaccination for the pediatric age group, and we have been very successful. Actually, we have shown how we have tackled poliomyelitis or basic infectious disease in our country. But the real challenge lies now. The government of India has started, number one, their very robust IT system, and how this has rolled out, how it has led to having correct data about the individuals who are vaccinated and where they are and how they are moving. And also, the profile of these individuals is now available on a single data platform. So One Health is already started when we started with healthcare workers, frontline workers, and people above 60 years, and people above 45 years and 60 years. And now we have a foundation not only of the reasons for vaccine hesitancy, not only knowing the constraints, not only knowing the adverse effects against vaccination through two major vaccine platforms, we know how this can be operationalized. And this so-called slow start, I feel it is the real foundation for India or for a long-term rollout. And now these individuals, 18 to 44, you have seen how they are leading from the front. The 2.45 crore individuals registering their intention to get vaccinated on the COVID platform, even before the immunization or vaccination has started on the ground. At the same time, within a span of 7 days, you must have seen new areas of vaccination, workplace vaccination, like you have also operationalized in your organization. We in the Indian Railways have operationalized workplace vaccination very effectively. And many big organizations have already had experience of workplace vaccinations in collaboration with the state government and the district administration. And all were on the IT platform of COVID. This is a huge advancement that India has made. And this shall be, I feel, in the next 3 months, will be the biggest success story for India. Because we will be able to show that people who may not be educated, who may be out of work, who may be earning very little amount of money, will still be coming out and getting themselves vaccinated. It's not a small thing. If you see the voting pattern in US and voting in India, we have been the front runner in actually running democracy on the ground. We actually shall be the front runner in running a successful mass adult vaccination program in the months to come. The past 3 months and the next 3 months shall be a story of success of public health and preventive health. And then the foundation for health promotion shall be laid. So I feel we have a big opportunity in this crisis, and only crisis brings out the best in the people and the organizations, which shall be visible in the next 3 months. That's what I feel.
Thank you, Dr. Rajiv. And also to add, and of course, India also ramping up vaccinations. We know that Serum Institute right now around 6 to 6.5 crores per month are ramping up to increase to around maybe 10 crores in few months. Maybe in July, they want to come to 7 or 8 crores and then coming to 10 crores. And even the Covaxin facility, the Bangalore facility is giving a uplift so that we'll have more vaccines there. And also Afghans Institute, they've started, the data transfer and all this paperwork has started. Probably we'll have more. And also Sputnik is, landing probably in maybe another few days to India. So vaccines from Russia. So I think a lot of hopes ahead. Definitely vaccines shortage will be eased up. And also the government has eased up all the vaccinations coming to India. They did not have the bridging study. Bridging study can go a long way the vaccinations.
Yes,
Maybe the first 100 needs to be followed up for 7 days. So that's a good move by Indian government. So let us hope for the best. And I'll take the second question, Dr. Jain. The basic protection against the virus at workplace is vaccination. The most economically productive group must be protected by mass vaccination, preferably at the respective workplace. What is the proposed plan of action? I think you've answered that because government also has, government of India has given a directive saying that you can have, if you have a hospital, you can have your own authority, registration as a vaccination center. Otherwise, you can associate with a private hospital saying that you are a workplace vaccination. So that option is also available. Probably the state governments will release more data on that, more guidelines on that, and all the states are waiting for that. I'll
Dr.
take
Guru
the
Prasad,
yes,
another
sir.
dimension which is unique to India.
Yes.
We have 92% are unorganized workers. Only 8% are organized. So when we talk of workplace vaccination, we must define what is the workplace. Real workplaces are our construction workers and the agriculture workers, which are in a very unorganized sector. And the strategy that India has is redefining what is the workplace. And if you only concentrate on large organization with only 8% of population, we shall be ignoring 92% workers, which are unorganized sector. So this strategy has to go together. The strategy of actually rolling out 18 to 44 group in the last is focusing on this very workplace vaccination. The vaccination rollout, if you see the expansion of vaccination centers in a manner which is safe and which is acceptable to individuals, not a small thing. Huge logistics involved in actually vaccinating 92% of workers who are predominantly in the 18 to 44. The construction work in the road sector, the construction work in infrastructure build up in the country employs predominantly these 18 to 44. The entire agriculture economy is based on these workers. And that when we talk of workplace vaccination, we forget what is the workplace in India. Workplace in US is different. In workplace in India is different. So we have to actually realize that workplaces are the real workplaces as revealed in India. So I think that will make people understand what is workplace vaccination.
True, sir, because all doctors here we belong to corporates. We just limit ourselves to corporate as an industry. So there is a wide, more open, definition is huge in that.
Yes.
I'll go to the next question, sir, from Dr. Samir Chowdhury from Vadodara. The oxygen nationalism about which you mentioned, what should be the effective methodology of robust interstate supply of oxygen?
Well, an interesting question. And today it is the feed for I think the media, so to say. The oxygen has been a blind spot, both production and distribution and consumption. All three dimensions, if you see, the production is predominantly in Eastern India, while consumption is in states which have very developed healthcare system, which is also skewed in favor of Western and Southern India. The need at the moment is also very diverse. Presently, as I told you, the pandemic rolling out, it is in Northern India and Central India, which is going to face the entire brunt. Uttar Pradesh, Bihar, Madhya Pradesh, Jharkhand, and Chhattisgarh will face a huge brunt of the pandemic in the months to come. At the same time, they have to tackle states like Karnataka, states like Gujarat, and also states which have shown a reasonably resilient health system, and also ensure that logistics are maintained. So vaccine subnationalism is going to remain for a few months because of the obvious issues of logistics, production, transport, and consumption. And I think the current crisis is being managed on a war footing. And again, the best of the people and the organization is visible in moving oxygen from the place of production to the place of consumption. If you see the way air, road, rail have been synchronized to deliver oxygen, I think that is another story in the making.
Yes, sir, you're right. This nationalism, recently in one of the interviews, Serum Institute CEO, Mr. Adar, he mentioned that, of course, he has to cater for the government of India, and his next interest will be Maharashtra, because he has to cater for his state. So this kind of things will remain, and within that, we have to somehow fight the pandemic. And also coming to this oxygen requirement, many corporates now, the CSR fund is can be diverted for this temporary COVID case facilities. For example, if they want to have a temporary facility, they can go ahead and use the the CSR fund.
CSR.
So that is been a very good initiative, and a lot of companies are working on that. And of course, even our company, we got a lot of proposals from different hospitals, like they want to expand the hospital and all. We need to get the fund, but we clearly told them these kind of funds can be utilized for not a capital investment like a ventilator and bed. It can be utilized for maybe doctor's salary or something, or a oxygen concentrator. And this is a very good thing to ease out the oxygen demand. People can have can convert their guest house into maybe a COVID care center, puts oxygen concentrator in that, and some companies procure oxygen concentrators. And whenever there is a requirement of sudden drop in saturation, they're going to send the concentrator to the employee's house till they find a bed. It's not a permanent solution till they find a bed. That is one good thing, we can all plan and do it. And many corporates, we have been doing that. We procure concentrators whenever there is a drop in oxygen saturation, middle of the night. Our ambulance going to pick from a medical center and supply to the employee's house till such time we get a bed. So these things, we can do, and corporates need to divert their CSR fund for these kind of activities, I believe.
And also I would like to add on the last dimension of oxygen usage. Auditing of oxygen usage, I feel the very science of proning has now come in vogue to increase the oxygen availability where oxygen is needed. Where do we need? Oxygen is needed in the alveoli and also cells of the body. And proning has proven to be so effective, simple technique. It does not require any external oxygen source, and yet the person improves dramatically. I've had number of individuals who would have been on need of continuous oxygen cylinders or oxygen concentrators supply, and they improved only on the basis of proning, by methodically, systematically, actually using proning on their themselves and coming out on tops. And they improved. They never needed external oxygen aid in the hospital. In fact, Dr. Guleria highlighted, you must have seen a mask is there and the person removes the mask to have his food or drink water or any fluid. He does not, the oxygen cylinder lever is never closed. Oxygen keeps on leaking and he continues to have food or water. Now people have realized how important this resource is. So during time of crisis, one realizes what are the innovative ways of conserving this scarce resource. I think that is another bright side of this so-called oxygen shortage, I would say.
Yeah, so thanks for that. We'll move to the next question. Whether Indian occupational health experts could anticipate this much of catastrophe in this second wave of pandemic? If yes, what was their recommendations? What is the recommendation to the prevent future catastrophe in the subsequent waves?
Interesting question, I would say. Anticipation and prediction is also the domain of psephologists, and also I feel people who are experts in climate. But like we said, tomorrow it's going to rain. Will it rain? If it does not rain, the person who is predicting rain is in bad repute. But coming on the right side of so-called prediction science is difficult. I would say, epidemiologists would always say that any infectious disease pandemic or epidemic will have a curve. But if it is a pandemic or a large-scale epidemic, you will have waves 1, 2, 3, 4, 5. And each wave, maybe initial waves are the second wave higher than the first or third wave higher than the second. This is a normal trend. But if you look at 1919 pandemic, you will find 3 distinct waves globally, I'm saying. Second wave was the highest. Third wave was the second lowest. First wave was the lowest amongst all the 3. So looking at convention of pandemic waves, one should say this second wave shall be the worst. And the third wave may be less worse, but third wave shall come. And that is how viruses evolve, because one must not underestimate the molecular genetics, the virology, molecular virology, and the evolution that the viruses normal course, they evolve and they become more robust, more evolved, and more lethal. But over time, the balance between immunity and the lethality and the immunity and the virulence balances off. Ultimately, through a series of waves, it becomes endemic. That is what is going to happen in this pandemic as well. COVID-19 virus will become endemic in due course, but only through a series of waves, and it is contingent on having appropriate vaccine at appropriate intervals to the vulnerable population in the time frame that is available, and the technology of vaccinology, how it evolves and how it is given to the people in the appropriate dosages and appropriate variety shall determine. Nobody today can predict human behavior, especially in India. In India, if you see elections, all the television channels will predict X result, and the people give you the Y result. That is going to happen in India in COVID-19 pandemic as well. It will be a big lesson for epidemiologists all across the world, and that, I think, is a lesson for mankind. And that is how we must always go beyond nationalism and to understand how geopolitics shall be determined in the post-COVID world. So epidemiology, infectious disease, and non-communicable disease shall go hand in hand. A new lesson, in, as I told in the report of the ILO also, the public health and occupational health and environment and national economy shall get knit together. People will try to understand that this is a well-connected world, and we cannot keep on separating or ignoring. We cannot continue to ignore these vital links in the human survival and human economy.
True, sir. Like whenever we present to management, we always put a slide like what is the cases per million in India. So we tell now it is around 12,000 per million, whereas US is going around 1 lakh per million. So then the rider is, if it is 12,000 per million, that means to say there is 9 lakh 86,000 people still to be infected. So that we should never forget. So we need to vaccinate them till we can't say that we are doing good, but still those many bodies are still left to be infected by the virus. We should be very cautious.
Very true.
So audience, anybody wants to ask any questions, please, the questions are open now. You can unmute and ask your questions, please.
Dr. Shyam Pigle is there. Dr. Tyagaraja is there. Dr. Maruti. Anyone? Dr. Shyam Pigle has unmuted. Yeah.
No, but I have no questions for you.
No question. Yeah, I would like your opinion, actually.
So we want your words, sir.
Very well. You have studied the subject. I especially appreciate the speed with which you have gone through the ILO document and put it laid bare in front of the audience. That has been fantastic, really. And of course, we know whatever are the things going on. Generally, we don't talk about politics, but unfortunately, the whole vaccine thing has been spoiled by the politics. Actually, the government of India was following a very appropriate policy of going after the senior people who are at more risk, people who are at more risk of dying. And they're doing it well. And that is when the demand came from the states that we should have the freedom to source our vaccine. It was their headlines in newspapers. And we should be allowed. And the elections and all those things on. So central government said, okay, you are allowed. Now it is something we don't have the vaccine and you are allowing. So you are going to do what?
Yes.
Today, a few hours ago, I read a news that Maharashtra government has asked private hospitals to return the vaccine.
Very true.
The vaccine which has already been given to the private hospitals, it wants the vaccine to be returned to the government and then government will administer it at its center. The government is planning one center for vaccination in one district.
Yes.
What are we going to do in 3 months if there is one center for vaccination in one district? I mean, this is horrible. It's very sad the way things are happening in our country. Yeah, one more thing, one positive thing I will also like to contribute, that when we say that we have about 7 to 8% of organized workers and rest are all unorganized workers, which is of course a fact. This 7% or 8% of organized workers generally comprise of factories, construction, plantation, and 3-4 categories. But it does not take into account the IT industry, the service industry, which is also a big chunk of people which we will be able to target through workplace vaccinations. So which is a strength that we have and we must capitalize on it. Of course, the challenge is big, but India had a successful vaccination for smallpox. It had a successful vaccination for polio, though it is still ongoing for whatever reasons. And we will definitely do it this way also. And I'm very happy about the overall positive angle that you have projected in the whole discourse today. So thank you.
Thank you so much.
Sir, I have one question, sir.
Dr. Tyagarajan, yes, welcome.
Yes, sir. Sir, Dr. Pingle is just telling some politics and all, but I'm just watching this NDTV for a long time, and I came to know Dr. Vidyasagar, who is one of the member of this one. He has mentioned that did government ignore warning and the red flags of second wave? What's your comment, sir? My question is, did government ignore warnings and red flags of second wave?
I don't think that is the fact on the ground. Government never ignored. In fact, the database from the institution which is responsible for this data management and modeling in Hyderabad, they had predicted and they had the models visible for second wave as well, and the timing also. But the scale of the wave in the best of modeling, sometimes it overestimates, sometimes it underestimates. That can happen. There is a margin of error in any model for that matter, because there are confounding factors. And in Indian situation, modeling, because of these confounding factors, may not be that accurate or that precise, so to say. So it's not that there is failure on the part of the modelers or in the top part of the response team. Predictions were available and they were very much on record. As the things roll out, one has to respond to the situation. One must not forget that this virus is having multifarious phases. If you see B.1, now B.1.617, which is a predominant virus in Maharashtra and Delhi, it has confounded the entire picture because of its fast infectivity and involving younger individuals, because of the simple reason that older individuals were given vaccination, younger vulnerable population was available, they were moving about, and they were infected with the virus, which is a variant B.1.1617. Now this variant speed and its geographical geospatial spread cannot be predicted by a simple model of epidemiology. For statistical purposes, these remain unpredictable, and this is what has happened. We are recording the spread that is occurring. That's why InstaCog, a group which studies the variants in India, is active at the current juncture, and we are able to track. And this shall also, please remember, this is a journey, early journey. We are still to travel a long journey. So we are still learning, and we should continue to learn. You must have seen the basic, philosophy of isolation has changed, and this has changed after a gap of almost 10 months. The guidelines which were issued for isolation in June 2020, only on 28th of April 2021, they've been revised. And if you compare the two, you will find how science of even isolation and quarantine has evolved. Could you recollect any year in the last 75 years of India's independence? So much science has been learned by people on such a large scale? Never. The term isolation, quarantine, and vaccine, the individuals across the board are now learning basic science of epidemiology. So what you've said, I think there's no there is no inaccuracy. There is no fact in the fact that the prediction, the information was not available. Information was available. Responses were in the making. But the changes in the virus makes the things very unpredictable and difficult to manage. But still, Indian government and the people have shown huge resilience in actually being able to tackle this against a very huge challenge of whatever deficiencies we have in the system in on the ground and the people's behavior. But we are tackling it to the best of our abilities. That is, I think, the bigger story.
So I think we can add on that because of the strains as well. As recently, Dr. Jamil and other virologists were, have a discussion where they mentioned because of the UK strain, where the Delhi and the Punjab region, and also what they name it as a Vidarbha strain in Maharashtra, and the strain in the Karnataka and the Andhra, and also a triple mutant strain in Bengal. So
Yeah.
these strains have become more virulent. So what people thought, what it protected them in maybe January, February, if they have the same habits in April and May, it won't work. They need to do something extra. So we need to tell all the people, maybe our employees, that we need to do extra. If you think that you are doing the same mask, below the nose in January, it won't work now because the virulence of strain is very higher. So that I think, and also they were mentioning that we are just lucky that our vaccines are working. And that's what Jamil mentioned also. We're just lucky that our vaccines are working. We should be very careful in future.
Yes. Dr. Maruti would like to say anything?
Thank you so much for the fantastic and very informative session, sir. Just my very straightforward question that we were much awaited for the vaccines will come from the May 1st, but I was watching the TV now, nothing is clear. How this thing's going to happen and how we have to be prepared in organization regarding this, because now also things seems to be quite uncertain about the vaccine, because that's the only one shield we can do it much better way. That's what, sir, your suggestion, opinion, sir.
There will be many stories of innovations and execution written on the ground in the next 1 month of huge vaccine rollout to the population, which is now the target population. A new chapter in vaccine administration to large populations is being written now. It has just begun. It may be little delayed, but at the end you will find all of us shall show a new lesson to the world. Please remember, Africa story has not yet begun. We shall be looking for Africa story in future. So India will show the way as well. So, and India is showing already the way how a large uneducated population can still surmount unsurmountable challenges. So this is, I think that the innovations on the ground in vaccine shall be rolled out in the next 1 month or so, and we shall actually show how effectively we can carry out a large vaccination program on the ground.
Yeah, sir.
I'm very hopeful. I'm very positive on this.
Yeah, that's the most awaited, and this is the only major option left us for the thing to do. Only thing is that we are struggling a lot for the medicines now, remdesivir and trastuzumab and other medications. If the same scenario happens with the vaccines, so things may go very difficult, because all other black markets and all, I think you will be knowing, sir. The similar thing happens to the vaccine, the things become very difficult for everyone. Hope that way won't happen for the vaccines, sir.
Let us hope for the best. On remdesivir, I have my own, the evidence-based medicine says something else, and people give huge importance to a drug which is not yet proven. But that's how as it is. The evidence has not favored the large solidarity trial, has not also shown the benefit in terms of mortality. The accurate mortality, accurate hospitalization rate was reduction of hospitalization by 1 day. So whether it is so important or so cost effective, one has to debate that issue. So let's not talk about these are issues which will continue to happen all across the world. As a wonder drug, there will be no wonder drug. If you see virology in last now 70 years, Do we have a very strong antiviral drug? I can only remember for a drug for hepatitis C, where 2 Nobel Prizes have been given. But other than that, where is the very effective curative antiviral drug? We don't have. So thinking of COVID-19 antiviral drug, I have my own doubts. Science has to evolve. Science of virology and molecular biology is evolving. Let's wait for that to evolve.
Yeah,
Dr.
yeah, sir.
Pingley has raised his hand.
Yeah, meanwhile, sir, actually, the morally, many people are very much down regarding this COVID. Once I'm just looking after many employees, once they heard that I'm COVID positive. So suddenly, most of the people, because of present scenario, a lot of media influence, they became morally very down, and it's impacting their health, and suddenly they becoming down. So morning he will be fine. I will see that, hear about from him saturation 97, but evening after getting a 4 o'clock, the reports, seeing that 5 o'clock he feel like I'm feeling dyspnea and saturation is 92, 93 like that. So it's directly impacting in morally also. So this is where actually a lot of counseling from our side we need to intervene as an occupation specialist. I think a lot of things are doing, and medical fraternity support in morally than medication. I feel, sir, in to some extent definitely moral support do helps
I agree.
in recovering from the COVID.
True. But at the same time, the ability of people to monitor their oxygen saturation and also understand what is the meaning of the reading is amazing. I feel this is a good ground for positive health and I would say health promotion. People tomorrow would be more prepared to measure their blood pressure, measure their blood sugar, and I feel this is an area for opportunity. People's actually practicing pronation as an effective oxygenation strategy. The whole field of lung health has evolved in such a short time. Amazing, amazing things are happening in India at the moment.
Yes, sir, like we all know that, the breathing is always associated with the emotions. How do you feel? If a person is tense, definitely his breathing is going to vary. And the breathing is very essential to get the adequate oxygen. So we also see, if the person is at home, he is at anxiety, his saturation drops. And by the time you put him in a good hospital, he doesn't require oxygen because he's free of anxiety, he's in safe hands. So these things work actually.
Yeah. Dr. Pingley has raised his hand, and Dr. Pingley wants to say something.
Not me. I feel that the whole COVID scenario is affected by two things. One is fear, and second is panic. And occupational health physicians have to come out of this twin melody. Fear and panic, we have to come out. And we should go more by evidence and less by eminence. We don't read things properly. We never look for evidence. And just because somebody is saying something, we go on practicing it. So I know people who started eating some tablets before even it was proved, and today evidence says that they were all useless, they have no role. Even the government has said that, but people were doing it. So we have to be more realistic, evidence based, do our studies well, then only we'll be able to guide the people, then only we'll be able to guide the management and our workers. We should not be adding to their anxiety and panic, but we should be, as Guru Prasad very rightly said, we should be moving them out of their anxiety and panic and giving them support and giving them reassurance. So occupational physicians have a lot of role to play into that. We must first of all understand that all nonsense prescriptions which are going out, I had even posted one of them, 20, 30, 35 medicines are being prescribed. What is this nonsense? We should know, we know that nothing works. It's only the body system which works, and the earliest signs of complications, the steroid works. We know all that. So we should propagate that uniformly, and we should not fall into this trap of whatever is going on outside. I mean, that's my personal view. Thank you.
We have Mr. Dr. Sen Gupta. Can you unmute yourself and ask your question? Dr. Sen Gupta.
Dr. Bhudev. Dr. Bhudev had raised his hand. That's why he's in the panel now. Probably
Okay.
he's not attentive.
Okay,
I'm
Dr.
not able to
Samir, you want
unmute.
to ask anything? Dr. Samir?
Dr. Samir Chaudhary.
No, sir. Actually, this I was attentively listening.
Hello? Dr. Gansham?
Hello, Dr. Jain.
Yes, Dr. Bhudev. Yes.
My question is during the first pandemic, first wave, we have done some unprecedented lockdown to reduce the transmission. In the second wave, in spite of the heavy casualties, heavy catastrophe, we have kept our economy open and things are going on in spite of the very difficult scenario. So is there any suggestion or recommendation to announce some planned lockdown, weekly curfews like things so that the transmission can be reduced?
Well, the lockdown as such, the terminology, I think in epidemiology, we should contain. I feel the more effective terminology is planned restrictions.
Yes,
And
yes,
focused planned restrictions done
yes,
in a focused local and geospatial manner are
Yes.
definitely more effective.
yes,
And that is the lesson we have learned through national lockdown last year.
yes,
Now that strategy, as you must have seen, the Ministry of Health on 25th of April and Ministry of Home Affairs on 28th of April have issued the guidelines to the state chief secretaries to monitor the situation on the ground. With the
Yes.
two aspects at the foremost index, the two, I think, key indicators will be more than 10% test positivity rate and more than 60% occupancy in the hospitals. Now, this data is easily available on the ground district wise and even at sub-district level to the district magistrate today. And they can actually implement restriction on district or sub-district level or municipal level or the ward level effectively now. They have sufficient experience also. And I have seen many district magistrates have immense skills in this regard, and they actually operationalize the powers that are available to them in that under the Disaster Management Act. We must not forget disasters in India have got three levels of management in India. One is the District Disaster Management Authority, the other is the State Disaster Management Authority, and the third is the National Disaster Management Authority. National Disaster Management Authority has already worked during the first phase. Now, this is the time when the state and the district disaster management authorities have to start working and seeing how effectively they are able to contain the pandemic at the current juncture and in the months to come. This shall also be a story of success of micro strategy and micro implementation and micro monitoring effectively done at the district and sub-district level.
Sir, unfortunately, in the present scenario in West Bengal, there is no political leadership. Everybody is waiting for the election result and the new government will take over. So unfortunately, in this transition period, there is the political leadership is lacking. So I think we are suffering because nobody is taking any firm decision. In India, without political leadership, nothing actually happens. The entire state is suffering, and unfortunately, after the election, there is no clear-cut mandate. If we have a not any clear-cut mandate, then again the entire administration is supposed to the state people will suffer because of the lack of any good leadership. So that is an apprehension from me.
Fine, I can understand the constraints the unique situation is
Yes.
creating, but let's wait for the better times. And
sir.
administration continues to work on a continuous basis, and hopefully things will be better rolled out in the months to come. Thank you.
Yes, thank you.
Any more questions? Any comments from anybody?
Dr. Ananta Krishna has come.
Yeah, he was having some network issues. He has come online now.
Right.
Dr. Madhuri, anybody wants to comment?
No, I have no questions. It
Okay.
was a very good session.
Dr. Nitali? Okay, sir, I think there are no more questions. So it was a wonderful session, sir. We learned a lot from you. And definitely, as usual, it was the wealth of knowledge we always receive from you. Thank you for your wonderful session, sir, especially the IULAR contents. And definitely, it is a homework for everybody. Now we have to go and read it. Once you have explained that, it will be easy for us to read. And I urge everybody to read that IULAR document so that we have more knowledge. We know what other countries are doing. Of course, we'll be doing almost the same, but still we get one point here and there, what best we can do to help our employees. Thank you, sir. Thank you very much. And thank you, OHD, for arranging this. Thank you very much. Thank you, all the participants. Thank you.
Thank you so much for moderating the session wonderfully. Thank you, Dr. Guru Prasad.
Thank you, sir. Thank you.